I think, and Arnie, if I say it wrong, you'll just correct me, it's not that what Dr. Kaplan is saying that MSCs don't exist. They may not exist in the numbers that we think we're getting them. And more importantly, they can function like MSCs in vitro, but they're not necessarily function that way when we use them. And that's also not the same thing as saying that they have no value or they may not have any efficacy. They just may not function in traditional paradigms. So our bodies have this innate desire to heal most of the time, ironically not so much in rotator cuff, but we're trying to figure out a way to sort of upregulate the system so we can do a better job. So Arnie, if I misspoke, or maybe oversimplified it, you'll tell me, but I think it's important to understand that because there is when the first time you're hearing some of this stuff, it's not that anyone's trying to be holier than thou or set a new bar. You can hear there's lots of things being done that don't have tons of evidence, but it follows the basic principles of just first do no harm and check yourself at the door and don't make claims that we can't possibly substantiate by what's in the literature. And it's kind of that simple because this is the first time we've put all of these concepts together in one place at one time with a group like this. So just a couple sort of sidebar comments. So I'm going to try not to be redundant and just point out where we are with orthobiologics and the rotator cuff and keep it pretty simple. Rotator cuff tears are interesting because they're one of the most common conditions that we see as we age. Maybe 30, 40, 50% of us, if we live long enough, will get a rotator cuff tear. If you look at the number of people with rotator cuff tears over the age of 60, there's probably 6 million people out there with them, yet we're only fixing 250 to 350,000 a year. So a lot of people have them, not a lot of people needing to get them fixed, and that's okay. Clinical outcomes are generally very good, but we still have a significant problem with maintaining the anatomic integrity because it is really a degenerative process. There's a number of biologic challenges when it comes to the cuff, and it's all of these things. And if you had the opportunity to read Atul Gawande's book, Being Mortal, there's a saying he has in there that says we're all sort of rotting from the inside out. And I think the rotator cuff is an excellent example of that because and we're shocked when we do this biomechanical repair, we test in the lab and companies come up with these amazing techniques and triple row and quadruple row techniques, and a year later it still fails because the tissue quality sucked to begin with and it still sucks a year later, okay? That's the problem with the rotator cuff. It's not unlike isolated meniscal tears in young people. They fail because they have poor quality tissue. So this is a perfect opportunity to actually affect biology because we actually have a real clinical problem. Well, some say, well, you don't have much of a clinical problem, but I think we do. If you look at the literature very carefully, one of the challenges is we don't all of our outcome scores don't place a significant emphasis on strength, and some of them not even on function. And when you carefully dissect the existing literature in patients who have healed versus who have not healed, there is a greater degree of satisfaction in those with healed cuffs. But that doesn't mean those who do not have a healed cuff do poorly. Speaking to the 5.5 million people over the age of 60 who run around with a rotator cuff tear and have no idea they have one, okay? So when they come to surgery, we're trying to regenerate the anthesis, and that's this mineralized fibrocartilage layer. But what we typically get essentially is scar and continuity, and they generally don't develop that mineralized fibrocartilage transition zone. So if we could figure out some way orthobiologically to do that, that would actually be a good thing. It probably happens at least in part because inflammation is part of the process and it leads to fibrosis rather than true tissue generation. That's probably why we do so poorly, in addition to the fact that we just have poor quality tissue, tenocytes, the bone, lots of different biologic factors. So you're going to hear about two different ways to manage this. One is by material properties and scaffolds, and we have a lecture on that. And then I'm just going to hone in on some of the things that we think we know about ways to improve the structural properties, either through cells or signals and so forth. So, this you've heard time and time again in various ways, but what leads to good tendon regeneration, this sort of tissue engineering concept, it's growth factors, it's progenitor cells, it's scaffolds. We think that's sort of the holy grail. And then don't forget about blood because blood's important too, and having a blood supply is also important to make this happen. So from a clinical perspective, what's available? So we've looked at this in a variety of ways, and really what's out there for us that's clinically available is PRP and bone marrow concentrate, although there's a couple other things that I'll mention. So a lot of basic science, which often doesn't translate into what happens in vivo, has looked at the effects of, say, PRP on normal tissue. So this is a study that aimed to just look at what are the effects of leukocyte-rich or leukocyte-poor PRP on disease-retrieved tissue. And essentially what we found in this culture study is that leukocyte-poor PRP promoted collagen synthesis and decreased catabolic cytokines versus leukocyte-rich when we looked at it in culture with degenerative tendon. So there's some suggestion that at least in vitro, we can do something positive in the presence of PRP and diseased tendon. Doesn't necessarily speak to what's going to happen in vivo, but at least in vitro. The other thing that probably warrants more discussion is that since we believe host parasites, MSCs, are important, there is some evidence that shows that PRP may actually signal for our own endogenous MSC. So maybe that's important. And it may be a poor man's way to sort of get this done because it's not particularly expensive and certainly not invasive compared to the other things that we do. There are some models that suggest that this might work, and this is something that's not often quoted. There are a few studies that have looked at what Steve Snyder talks about, this crimson duvet phenomenon, which is debriding the tuberosity. There are a couple of studies out there that have actually looked at the equivalent of marrow stimulation on the tuberosity and shown that patients can do very well that have 2 tendon tears, and when they compare to control with anatomic evaluation, they actually did better when a marrow stimulation technique was performed. So this is sort of a poor person's way to develop a bleeding environment. There's also some data that shows that there's lots of growth factors that come about when you do a subacromial decompression and disrupt the acromion. So there seems to be some suggestion that just this biologic milieu can be improved on by dealing with local factors. Now, you've seen this 100 ways sideways, and there's no way it'll bore you to death if we go through every single paper. And this is an adaptation from one of Jorge Chala's slides that you're seeing. It's like doing a sort of a meta-analysis of what's actually out there in the literature. And we got to be very careful about just using this as a Cliff Notes version of, yeah, this is okay, do it because the literature supports it. I saw this one slide that had a green light. I mean, there's a lot of caveats. And I think that if you look at the synthesis of as close as we can get for apples to apples, there seems to be a suggestion that in double row repairs, ironically for small and medium tears, not the large ones, and the absence of a fibrin matrix, just PRP without a fibrin matrix, there's a suggestion that anatomic healing can be better. So I use the word anatomic because to date, very few, if any of these studies have actually shown significant clinical differences. But I would submit to you, if you turn to the literature and you say our goal is in this patient population who can't compensate or adapt to having a rotator cuff tear and actually needs a healed cuff to hopefully get better, anatomic integrity seems to matter when you get more granular in looking at the literature. There have been some alternative ways that PRP has been looked at. There was a study, I think JT commented on this, where they used interstitial PRP versus saline, and it did not show that partial thickness cuff tears had a change. Now, this is a problem even of itself, because what is tendinosis? What's a partial cuff tear by MRI? That's a big black box, and frankly, probably not even the pain generator for most of these patients who present with MRI evidence of an abnormality. Another study looked at the use of PRP after rotator cuff repair to see if that made a difference, and there was no change in function after adding PRP postoperatively. So some interesting twists. Okay, so what about using these MSCs in any fashion that they may operate when we inject them at the time of surgery? So you've already heard about what they do, and this is sort of, in some ways, a summary of what Arnie pointed out, the way they might behave, not the traditional way, downstream lineage transforming into different musculoskeletal tissues, but actually functioning, if you will, as with a paracrine effect and maybe promoting all of these things in some biologic environment. So are they clinically relevant? Well, one way to get at it, and this is a little bit of the chicken and the egg concept, was a study that Hernigo looked at patients who had a rotator cuff tear and obtained bone marrow concentrate from the greater tuberosity, and his conclusion was that patients without a rotator cuff tear had more MSCs. Now, I don't really know what to make of that because we don't know, again, if this is a chicken and the egg phenomenon, but those who didn't have a tear had more MSCs when bone marrow was harvested or obtained from their greater tuberosity compared to those who did have a tear. We've gotten increasingly interested in this, and this is just our sort of introductory pathway to do some basic science in this area, and this is one of our former fellows, Mandeep Virk, who looked at the gene expression of progenitor cells that were isolated from the rat muscle tendon or the muscle tendon junction. And the concept is that, look, we don't always, if we're going to start looking for local sources of cells to maybe upregulate or trick the environment, Can we use diseased tissue? Can we use tissue from the muscle itself or somewhere in transition? And the genetic profile, the gene expression of the tendon edge and the muscle tendon junction was very similar. So as we start thinking about ways to sort of harness our body's ability to heal and use local tissue, for example, we have our eye now on ways to actually use various parts of the muscle tendon junction and even the bursa for this purpose. So this is all just really introductory stuff to get our arms around what baseline is. There was another interesting study that drives home the importance of the fact that cells in isolation may not matter. This is a study that looked at bone marrow-derived MSCs in a rat, rotator cuff repair model, and the take-home was that the cells alone did not improve healing, and it highlights the interest in that maybe we need something more than cells, some other soluble factor or even a scaffold to make it work. So what are the clinical outcomes that we've seen in two studies that have been published? One is using bone marrow concentrate, and that's the one that JT referred to, and that was by Hernigau. And it's an interesting study. It actually suggested there was some dose response to the number of MSCs that were present through flow cytometry by characterizing these patients. But it's a pretty profound difference at 10 years. 45 patients in each group, 87% anatomic healing by ultrasound versus 44% in those who didn't receive bone marrow concentrate at the time of their surgery. There was another study that looked at adipose tissue. It was a level 3 matched control study that basically showed anatomic integrity at the level of 28.5% without adipose tissue and 14% with. To my knowledge, those are the only two published studies that have looked at this clinically, and they both actually showed a difference anatomically, but not necessarily clinically. So as JT alluded to, we're almost done with this trial, and I'll just share with you where we're at. It's a randomized study. Everyone gets a transosseous equivalent repair. Anyone who had a subscap tear is excluded, and everyone has to follow the basic principle. And we have more data than this, but I'll just share with you what we just recently presented, not published, is we had 20 in the bone marrow concentrate, 28 in the control, and we looked at the Sagaya score, which is basically a 5-point scale to evaluate by MRI the anatomy of the cuff. And we saw essentially a 1-point difference that was statistically significant by MRI, looking at anatomic integrity of the cuff in the group that received bone marrow concentrate, 60 cc's, ASIS, spun down, they're all being characterized with a smear in the operating room to look at cell morphology, and then all getting flow cytometry showing an uptick in the number of mononucleated cells and with proper markers. And so essentially we showed a 1-point difference by MRI at 1 year. So we're still collecting data, but that's our preliminary results. There are some other options that are interesting. This was a bone marrow concentrate injection again into partial thickness tears, bursal-sided tears predominated. Again, I'm not really sure what this clinical entity is because you can find these a dime a dozen by MRI, but they basically performed a matched case control series, intratendinous bone marrow adipose MSCs. Now this is like that PRP study where they did it intratendinous and did not see an anatomic difference. Here what they did is they injected adipose MSCs into partial thickness rotator cuff abnormalities in MRI, and they actually showed a resolution on the bursal side of that defect that was seen by MRI. Another idea that's interesting that's being floated is that, that's being floated is the concept of using local tissue as a low-cost way to upregulate the environment. So this is, that's how fast we move, yeah? So this is a subacromial bursectomy being performed, collecting it in a container or a vesicle, sort of like a Lucan's trap. And basically there's a increasing amount of literature that is suggesting that this may be a local source of progenitor cells. How we have to process it, do we have to chop it up, do we have to have it undergo enzymatic digestion, which would be more than minimally manipulated? It's not entirely clear, but focusing on low-cost ways to get access to biologically available tissue is of increasing interest, and especially for to overcome some of the regulatory burdens outside the United States, even as it relates to cartilage repair. And then the final one is augmenting anthesis. This is the problem that we have to begin with, and there's some interesting data that looks at the use of demineralized bone matrix placed right at the tendon-bone interface, sort of juxtaposed to the repair site, and this intuitively may make a whole lot of sense. So also there's some supporting data that this may be beneficial. So I think our focus should be on the fact that the rotator cuff tears are really poor tendon biology. They're largely degenerative, and they're always degenerative in the end, so we're repairing poor quality tissue. When they try to heal, it's largely scar and continuity. Growth factors are probably not going to be enough to give us what we're looking for. We likely need pluripotent cells that are signaled for or licensed to actually promote the local environment and to help recreate a healthier enthesis. And then I would say that it's not conclusive, but we're seeing an increased number of studies that are in favor of PRP for small to medium tears at the tendon-bone interface and potentially bone marrow concentrate to make a difference structurally, but not necessarily clinically. Thank you.